Hi, everyone. Welcome back. I'm Dr. Samantha, the maternity mentor, here for another one of our live Q&A sessions. I'm a board-certified psychiatric nurse practitioner, and I spent a good part of my career, over a decade, working in the hospital and maternal child areas. And so that's why we started this channel for you. Remember, we're over on Facebook and Instagram for additional content. We will link those into the description. Please like and subscribe to the channel. Subscribing to the channel really helps me out as a content creator because I'm going to start again, guys, because I just had a flash and my timer started over. So I'm Dr. Samantha, the maternity mentor, here for another one of our live Q&A sessions on Monday. I'm a board-certified psychiatric nurse practitioner, and I spent a good part of my career, over a decade, working in the hospital in the maternal child areas. Please remember to like and subscribe to the channel. Subscribing to the channel really helps me out as a content creator, and it allows me to be a part of the YouTube Health platform. Remember, we're also on Facebook and Instagram for additional content. And for those of you who are joining me tonight, I am in not so sunny South Florida, where it is currently thunderstorming outside. So if we lose power and I suddenly go dark, I promise we will be back next week to answer any questions that we missed. So I'm going to go ahead and get started with some of the questions that you guys put onto the channel this week. But if you have any questions, please feel free to put them into the chat. So we had a lot of interesting questions, and I'm going to actually start out with one that was on my sexually transmitted diseases video. And it said, I tested positive for syphilis 8 years ago, and I've undergone treatment many times. However, every time I finish the treatment, I experience the same symptoms when I touch my child. What could be the problem? And if my child has it, is there a way to treat it? So I thought this was a great question to start out with. So syphilis is one of many sexually transmitted diseases. And syphilis requires treatment with antibiotics. If you don't treat syphilis with antibiotics, it can lead to a lot more devastating complications. If you're pregnant with syphilis, we want to treat you because the baby actually can contract syphilis. However, when you are talking about 8 years of repeated syphilis positive tests, it's actually probably something else. It's probably treatment resistant, antibiotic resistant form of syphilis. Because of all of our overuse of antibiotics and the incorrect use of antibiotics, we now have a whole bunch of diseases that are no longer able to be treated with standard antibiotics. And a lot of the sexually transmitted diseases are in that category. We're finding more and more that we have to give heavier and heavier doses of antibiotics in order to clear these out from our system. So it's not something that I think you're getting from your child. I think that just happens to be coincidence. What I think is actually happening is that you have treatment resistant syphilis. What you want to do is you want to get in with a specialist, an infectious disease doctor. Infectious disease doctors are the specialists in infections and treatment resistant bacterial infections and viral infections, all that stuff. So that's the person who would be best able to direct your care and would be able to kind of go through that process with you. And we had a couple questions on antibiotics. So I think that this question on syphilis, which I believe is a treatment resistant syphilis, is a great segue into antibiotics. Antibiotics only treat bacteria. This is why when you take your child to the pediatrician for a runny nose, they don't just give you an antibiotic anymore. And guys, if you go to the doctor and you just have basic symptoms and they say, I think it's a virus, don't take antibiotics because we overuse them and it's leading to treatment resistant bacteria. In fact, in my house, we do not use any antibacterial soap and we do not use the hand sanitizer. So when you're washing your hands, regular soap and water is all you need. It's actually the mechanical action of washing your hands that helps get rid of the germs. It's not anything else. The more you rub, which is why they tell you to do it for a minute, and the better you rub, the better it's going to be. Also, the little fat molecules like in your soap, they kind of capture some of those germs. And then when you rinse, you rinse off the bacteria. But again, it's this. I no longer use antibacterial soap because that's part of what's leading to treatment-resistant bacterial infections. And that came out maybe a decade ago. So I want you guys to understand all this stuff that we have that's antibiotics, you have to use it judiciously. You have to be careful and only use it when you need it. Now, when it comes to actually taking a medication, if you've been prescribed an antibiotic, that means your doctor thinks that you have a bacterial infection. When they give you this antibiotic, you have to take it all as prescribed. Now, the nice thing about antibiotics is they help you feel better fast. That's like a great thing. But just because you feel better doesn't mean the infection is gone. In fact, it's not gone. It's just that you've gotten rid of a whole bunch of the bacteria. But there's still bacteria there fighting the good fight. They're trying to replicate, they're trying to do what they need to do. But when you stop, like when they see this antibiotic coming, they figure out how to get around it. They build a defense. So you stop and eventually they start multiplying and you get sick again. So you're like, oh, I need to take the antibiotic. I should have finished it. You go to take it again. It's not going to work because these bacteria that are left have a defense wall. They're stronger. There's lots of them. That's antibacterial resistance. So we want to make sure that we are taking everything as prescribed, even if you start to feel better. And that's one of the tricky things with antibiotics. A lot of people are really scared to take the full course, especially if they're pregnant, but that's actually better for you. Infection is one of the leading causes of like preterm birth, miscarriage. It can be devastating to your pregnancy. And so we want to make sure we get treated properly. And this includes urinary tract infections. It also includes viral infections, and it includes yeast and fungal infections. So again, if you have anything going on, we want to make sure it's treated. Now, a lot of you guys then ask me questions about specific antibiotics. So one of them is the antibiotic metronidazole capsule safe for use during pregnancy? So this medication gets a really bad rap on the internet. I'm not really sure why. We use it like all the time. Metronidazole is really good for bacterial vaginosis and other infections. It is safe. Now, all the antibiotics pretty much are risk versus benefit. And this is really important, guys. When you're being prescribed something or you're being asked to do a procedure, your healthcare provider should be giving you risk versus benefit, okay? And with antibiotics, there's always a risk that it can make you sick, that it could give you diarrhea, which can lead to cramping or contractions. You could have an allergic reaction to it. But these antibiotics these two antibiotics I'm going to mention tonight, there's no data to say, even in animal studies, that they would cause any types of issues. So one of the things we do as healthcare providers is we look for sources of good data. And one of the references I use is Thomas Hale's medication guide. He has a rating scale for medications and their safety for both pregnancy and for lactation. And so it's a really good resource for a lot of healthcare providers. Your local pharmacist also has access to a lot of different research and reviews, and they actually have specialized training in medicating all sorts of people. So if you are concerned about what your healthcare provider is like prescribing and you want a second opinion, your pharmacist is actually a really good second opinion. So these are a couple places for you to go. But your healthcare provider ultimately should be telling you what the risk versus benefit is. Metronidazole is a risk versus benefit, but it's considered a P2, which is probably safe. The other question I got was, I'm 26 weeks pregnant. I was given cefixime tablets. Is this safe to use during pregnancy? And the answer again is yes, risk versus benefit. It's considered a P2. So these are two great medications that can definitely help you and treat your bacterial infection. For any of you guys who are joining me, please feel free to put your questions into the chat. And it's raining like crazy here, so if I cut out, that's why. All right, so we got a question on bleeding. So it said, hello, doc, I have a question. What kind of bleeding is this? I'm 5 weeks pregnant and there's a very small amount of dark red/brown blood coming out, which worries me. So this is a great kind of question to talk about for bleeding. So bleeding is not considered normal during pregnancy. During the first trimester, there are a lot of reasons that you could be bleeding that are kind of normal and not a threat to the pregnancy. There are also some reasons for bleeding that we're a little concerned about. In the second and third trimester, if we see bleeding, we are a lot more concerned at that time because the reasons are usually indicative of an issue or a problem. But the only other time we will see bleeding that is actually considered normal is during labor. So you will have some bleeding during labor, and that's considered normal. In the first trimester, there's a whole bunch of reasons you might bleed. You could bleed from sex. You could bleed from placental position. You could bleed from your body not realizing you were pregnant and getting a period. There's implantation bleeding. There's subchorionic hemorrhage, which is a little pool of blood underneath the placenta. So these are just some of the many reasons you could bleed. You could bleed from infection. A lot of women will bleed from infection. So when you have dark red or brown blood, that's usually a sign that it's actually old blood. It's a bleed that is resolving. So it's probably one of the things that I just mentioned, but it sounds like it's getting better. Now, that being said, any bleeding, guys, any bleeding at all, you need to call your healthcare provider. So we have several videos on bleeding. I have a video on the colors of bleeding, which tells you a lot more about them. I have a video on what to expect in the hospital and what tests to ask for if you show up bleeding. And I have a couple bleeding videos themselves. But there's different stages of bleeding. Pink is usually like fresh blood that's mixed with some kind of secretion, like mucus or something like that. Red is active bleeding. Dark red to brown is actually transitioning to a bleed that is resolving. So brown is considered old blood. It's a resolved bleed. But you should always contact your healthcare provider. That's what they make the big money for. They are there 24 hours a day to answer your calls, and you should call. It doesn't matter if you call every day. That's what you need to do. That's what you need to do. Now, here's another thing with bleeding that I think is very concerning, and I don't think we talk about a lot. So here's the scenario. You have a little bit of bleeding, okay? You have some spotting. You're like 7-8 weeks pregnant, some spotting. You call up your doctor. They bring you in. And they find out that you have a little yeast infection or something. So they give you some treatment, you go home, and you're better. And then 3 or 4 days later, you start bleeding again. And you say to yourself, oh, it's just the yeast infection. Don't do that, guys, okay? If you've had a symptom that needed to be treated, and that symptom resolves and then reappears, even 2 days later, you need to call the doctor again. Do not assume the same symptom is for the same reason, because the first time you bleed could be implantation bleeding, and the second time you bleed could be a placental issue. So you always want to make sure that you're double checking every time you get like that new symptom, okay? All right, so going to the next one. We had a question on my pelvic pain video, which sounds so much like a student, but we'll see. It said, can you explain what happens to the pelvis during pregnancy? Specifically, what changes occur in the bone structure and which types of pelvic anatomy or shapes tend to have issues? So I love this question. I think pelvic pain is something that's vastly under recognized and vastly undertreated. And we don't seem to have a lot of sympathy for a lot of moms as to how bad it can actually be for them. So during your pregnancy, the placenta starts secreting a hormone called relaxin. And relaxin's job is to relax all the joints in your body. It's actually supposed to be relaxing the pelvis because you have ligaments and stuff that are holding your pelvis together, and they need to stretch apart to give the baby more room and to allow you to give birth. You've got to pass the baby through the pelvis. So that relaxin's job is to help relax those tendons. That creates a loosening. And sometimes with that loosening, your pelvis can kind of get misaligned, which can cause some of the pain, or you can actually stretch further. This relaxin, this is the same thing that, have you ever seen a woman whose feet get flatter and larger or noses get bigger? It's the same idea. That hormone is relaxing everything. And so as a result, you can see some changes in other places. It's a really important hormone and it really helps you deliver your baby. Now, as for what types of pelvises, I'm not going to say that there's any type or another because that just varies from person to person. What I will tell you is there is right now a lot of issues related to C-sections that are being done because the provider is saying that the pelvis is too small to deliver the baby. So this is a very controversial kind of subject. So sometimes what'll happen is there is actually a pelvis that is too small. And if you try to deliver that baby, it could be life-threatening to both mom and baby. But other times you just have a provider who is just not trying to deliver a baby vaginally. There's a lot of reasons why they can do it. Frankly, I've seen some providers who are very lazy or they get impatient and they don't want to have a long induction. Inductions that are more than one day, in my opinion, are the best inductions. So there's a lot of reasons why that could happen. One of the reasons why I mention this is one of the reasons you should interview your healthcare provider prior to getting pregnant. You want to make sure you know who your OBGYN or midwife is and what some of the things they do for you are. One of the questions you should ask is, what is their C-section rate and what is their episiotomy rate? If you are finding a provider has a high rate for either one of these, then that's a provider you may not want to go with. And we did a fascinating little experiment in one of the hospitals that I worked at. And in that hospital, what happened was they wanted to reduce episiotomy rates. And so what they did is they posted all of the providers with their episiotomy rate right next to it. So you could see the highest to the lowest. Within 1 month, 80% reduction in episiotomies across the board because they didn't want to be at the number one spot. So a lot of different facilities outside of mine are actually trying this same technique with C-sections. There's now stricter guidelines for it because this oh my God, what's the term? It's pelvic disproportion, cephalopelvic disproportion. I just want to make sure I said it right. That's actually the term when your pelvis is not the right size. This is supposedly this really big issue, and it's not as big as some of these providers say. Now, that being said, there is some research that's going on, and it looks like women's pelvises are actually evolutionarily getting smaller because our C-section rates have been so high that women are not really, they're not able to like deliver these big babies anymore because we're not doing it a lot. So there's some stuff going on about that, which is really kind of cool. For those of you who are joining me, please feel free to put your questions into the chat. I'm just going through some of the questions that we got on the videos this week. So I got a question on my yeast infection video. Why has my baby stopped feeding on my milk when I had a yeast infection, even though her mouth has healed? So yeast infections of the breast are very common, unfortunately. It's usually caused by like deep, it usually feels like a deep stabbing pain, or you can feel like a burning pain. And so that pain is terrible, but it's your signal that you probably have a yeast infection. If you are breastfeeding and you have a yeast infection, your baby has that yeast infection, even if they don't have the symptoms. And you want to make sure both of you get treated. If both of you don't get treated at the same time, you're just going to pass that infection back and forth. She mentions in her question, why is the baby not eating when her mouth is healed? Yeast infection or thrush in a baby's mouth is extremely painful, and oftentimes they won't want to eat. But here's the thing. If they fed too many times on your breast while in pain, they can actually have a negative association with that, and that's why she might be refusing. Unfortunately, what it does is it takes a lot of time and practice to potentially get her back on the breast, but it's probably related to that. The only other thing I can say is that maybe the yeast infection hasn't quite cleared. If you're still on medication, sometimes that will flavor the milk, and they just don't like the flavor of that. For those of you who don't know, if you eat certain things, it will actually flavor your milk. So a couple examples is garlic. Garlic actually flavors your milk, as well as beer, for example. And one of the things that we try to encourage women to do of all cultures is eat the foods that you enjoy regularly, because all those spices and stuff that you normally cook with, those are actually going to somewhat flavor your breast milk, and it kind of gets your baby used to what they're going to be eating later on. So it's kind of cool little thing, and you should definitely do that. So I got another question on my aspirin video, and it says, I've been told I should take baby aspirin because I'm 42 and it's been more than 10 years since my last pregnancy. Is this enough of a reason to take baby aspirin? So baby aspirin is often used for the prevention of preeclampsia, or for the treatment of preeclampsia. We don't use it anymore for miscarriage. There's no real data to say that it helps with miscarriage, although you'll still have providers giving it for that reason. When you are at risk for preeclampsia, especially if you have 2 or more risk factors, the recommendation is to take baby aspirin. So one of the things is, when I looked, at your question, first of all, your age alone, advanced maternal age, is absolutely a reason and a risk factor for preeclampsia. Second to that, you mentioned not having a baby for over 10 years. So believe it or not, when you haven't had a baby for over 10 years like that, they sometimes will consider it your first pregnancy. It's because so much time has passed. And first pregnancies are at higher risk for preeclampsia. So they would go ahead and give it to you for that. And then it depends. There may be other reasons why, or other risk factors you might have. If you're obese, if you are of a certain ethnicity, these are all things that they're going to take into account, and those will increase your risk. So baby aspirin's usually really benign. It doesn't have a lot of side effects, and it can really help you out. So I really encourage you to take it if they've recommended it, because the benefits probably far outweigh the risks. For those of you who are joining me, please feel free to put your questions into the chat, because I don't have that many questions left. I'm going to go with a gestational diabetes question. My wife just tested positive for this, and we're confused because she hardly eats any of these foods. She moderately consumes simple carbs from white rice, noodles, and cereal, as well as honey, ice cream, and butter. That's all I can think of. Is this something you see often? Should we be concerned or eliminate those few things entirely? So gestational diabetes is a beast, and it really can be very detrimental during pregnancy. It puts you at risk for diabetes for the rest of your life. It puts you at a higher risk of a late preterm miscarriage. It puts the baby at a lot of risk for complications after birth. So it's very important that it get treated fast, aggressively, and really, you got to go for it. In order to help treat it with your diet, you need to avoid carbs. And I have a video on the keto diet, because the keto diet is a low carb diet that focuses on healthy foods. So that's one example of one of the things that you could potentially focus on to eat. Now, a lot of times we hear some of these things and we assume that when we're saying carbs or sugar, we're talking about candy. But those simple carbs that were actually mentioned, noodles, rice is sugar, guys. Rice is nothing but sugar. And I know that seems weird because it's not sweet, but it's all carbs. It's complete sugar. And then most cereals have a lot of sugar. One of the things that people love to eat is oatmeal. Oatmeal is totally sugar. So the thing is, these are all very processed foods. So when you're talking, if you're going to eat sugar, you want to eat a strawberry or a blueberry. A strawberry or a blueberry may seem like it has more sugar, but it's also got fiber and other nutrients in it that make it far better for you than the rice. When you have diabetes, you want to focus on protein, healthy fats, and low carb. You can get protein from a variety of sources. And then your healthy fats can include olive oil, nuts, different things like that. But this is what's really good for a person with diabetes. So I would tell you that probably part of the reason why there's still an issue or this might have developed is these are actually high sugar foods that she's eating. So I would try to focus on different foods from that. For any of you who are joining me, hi, please feel free to put your questions into the chat because I only have one question left. Otherwise, I'm going to be ending early, guys. Okay. I am 6 weeks pregnant and I have PTSD and major depression. Can I take Zoloft, which I used to take? I've currently stopped all my meds. So, I am now in psychiatry. I moved from the hospital and maternity care into psychiatry because I felt that women were not getting the proper care of their psychiatric illness during pregnancy and when they were breastfeeding. And then as I did my education, I actually did part of my doctoral project on postpartum depression in fathers. And it's because dads are also being left out and they really need their own type of support and treatment. So I'm very passionate about this. There's a lot of evidence to say that untreated mood disorders are actually a risk for miscarriage, preterm birth, low birth weight, developmental issues later on, and that most of the time it is better to treat those illnesses. There is about a 2% risk of having a birth defect of anything, like just walking down the street, no psychiatric illness, no meds, nothing. You're walking down the street, there's a 2% risk of something like that. Untreated anxiety or depression increases that risk to like 4 or 5%. So it's very important. So when you use a medication, you're actually bringing it back down again. And so that's why it's so important. So there's a lot of different meds that you can take, more meds than you can even imagine. And every day there's a whole bunch of basically data banks and stuff where women are volunteering to report the meds they're on, the conditions they have. Doctors are doing the same to study the safety and efficacy the best way we can, because you can't test a drug on a woman. It's unethical. If she's pregnant, you can't do that. So what we have to do is look at the safety profile for the drug and the risk versus benefits and all that other stuff. Zoloft is sertraline. It's an SSRI, serotonin selective reuptake inhibitor. These are medications we commonly call antidepressants, but they actually are really good at treating anxiety too. Sertraline is also well known for treating panic disorder and OCD, obsessive compulsive disorder. Zoloft is a fantastic drug, and frankly, it's the one that's number one used in OB. I don't know why. There's nothing that's different about it from the other SSRIs, but for some reason, somebody somewhere one time prescribed like Zoloft and everybody was happy and healthy. And from there, that's what it was. So everybody gets Zoloft like all the time. So this is absolutely a medication that you could use during pregnancy, and it would be very important for you to go ahead and get your depression or anxiety treated. Okay, so now I have a question in the chat. Please feel free to put your questions in the chat. Are you still at risk for eclampsia after delivery? So yes, 1000% yes. Up to 6 weeks after delivery, you are at risk for postpartum preeclampsia. So eclampsia is actually when you start having seizures. Preeclampsia is right before that. As your blood pressure rises, it puts you at a higher risk of having a seizure, which is what we're trying to avoid. So you can have that for up to 6 weeks postpartum. And we actually treat it the same way we would treat it for a pregnant woman. We do IV magnesium. We usually have you in the hospital and we're monitoring you. Some of the signs of postpartum preeclampsia are the same as before. Massive swelling. If you gain 2 pounds in swelling overnight, that's a big warning sign. Headache. This is a headache that seems different and will not go away no matter what you do. Tylenol, rest, nothing. It keeps going no matter what. Vision changes. So this can be blurry vision. It can be tunnel vision. It could be spots in front of your eyes. It could be anything that you see that is like bothering your vision. That is a risk factor for preeclampsia. Or upper abdominal pain, usually on the right side. That's also a potential sign. If you have any of these signs and you have a blood pressure cuff, you should take your blood pressure or you should just call your doctor right away. In our area, we actually have these blue bracelets. So I'm in South Florida, and so it's a large metropolitan area. And frankly, all the counties from Palm Beach to Monroe were all considered one giant metro area. And so what's happened now is all of the hospitals that deliver babies and all of the emergency rooms and all of the ambulances now follow this one kind of idea. When women deliver here, when women are diagnosed during pregnancy and or in the hospital, they have this. When they go home, they're given a blue, like rubber bracelet. So this blue bracelet tells anybody in healthcare who is picking this person up. So if she is unconscious in a car accident, that blue bracelet lets them know that within the last 6 weeks, she had a baby and she had high blood pressure. And this way, women are actually getting treated faster, better, and safer because preeclampsia is different. It is not the same as regular blood pressure. And I'll give you an example. Magnesium is an electrolyte. It's a really cool electrolyte, has a lot of good purposes. But you can overdo it with magnesium when you're giving it IV. And I mean, you can really overdo it. You could kill somebody. So most of the time in all the other parts of the hospital, they'll give maybe like 1 gram. In postpartum, we sometimes give 2 to 4 grams of like magnesium in an IV. Nobody else does that. Nobody else would dream of doing that. They all look at us like we're crazy. It's considered extremely dangerous in any other part of medicine. But for us, it's standard. We have a lot of safety protocols in place. There's a lot of monitoring. So it's really well done. But we use those high doses because that's what helps protect the baby and prevent those seizures. So going back to like something like a car accident, if you're a mom who had eclampsia and you've been in this car accident, you're unconscious and your blood pressure is rising, they need to know that this is probably preeclampsia versus thinking it's just regular blood pressure issues, because regular blood pressure issues would be handled differently and potentially they would not use something like magnesium because they didn't know what was going on. So that's what I would tell you about that. I don't have any more questions. So if any of you guys have questions, please feel free to put them into the chat. I think that it's really important, guys, that you make sure that you're having good, active conversations with your healthcare provider. Make sure that they're talking to you and telling you risks versus benefits of all the medications that you're giving. Make sure if you feel like something's wrong that you talk to your healthcare provider. That's what they're here for. Don't be afraid to show up in the hospital, even if it's over and over again, because it's better to get checked out and everything is good than to not get checked out and something is wrong and we could be doing something which could prevent a complication. I think it's really great that you guys are all here. Remember, I've got tons of content. I have content everywhere from starting at first trimester all the way to after you deliver. So please feel free to check all of that out. We're on Facebook and Instagram for additional content. We link those into the description. And we are here every Monday at 9 p.m. Eastern Standard Time to answer your questions live. We feel really strongly about this. Anything that you want to ask or suggest, you can do that on the videos. We look through those. Those were most of the questions that I answered today. And then, of course, anything live. I am done for tonight, and it's kind of like storming like crazy where I'm at. And so I am going to go ahead and end tonight since there doesn't seem to be any other questions. I really appreciate you all. I'm Dr. Samantha, the maternity mentor, and I am here to say thank you, thank you, thank you. Like and subscribe, and bye for now.